Hello and welcome to our presentation today on the development of classifications at the Independent Hospital Pricing Authority. My name is Anne Elsworthy and I'm the Director of Acute Care Classifications at IHPA, and my colleague and co-presenter is Natalie Bryant, the Director of Classification Projects at IHPA. Our presentation today covers three areas. Firstly, an overview of health classifications, a look at the ICD-10 ACHI ACS classification system, and lastly, a review of IHPA's activity-based funding classifications. An overview of health classifications. IHPA has a number of functions specified under the National Health Reform Agreement. One of those is specifying, refining, and developing new classifications. Health classifications are able to provide the healthcare sector with a nationally consistent method of classifying all types of patients, their treatment, and associated costs. They do this by providing a structured way to organise health information into standard groupings for statistical reporting. They also provide rules for collecting and coding clinical information that are standardised nationally and internationally to ensure patient data are grouped consistently and accurately. By placing health data into meaningful, distinct and stable groups, it makes it easier to identify patterns and trends and enables better decision making and management of the healthcare system. The process of clinical coding is the translation of information, diagnoses and interventions from the clinical record of a patient into alphanumeric codes according to a health classification system. What is the difference between a classification and a terminology? Classifications such as ICD-10 and clinical terminologies such as SNOMED CT both manage clinical information. But a classification is mono-hierarchical, comprehensive, provides aggregation, and it reflects its hierarchical structure. Whereas a terminology is polyhierarchical, it doesn't have residual categories such as other and unspecified codes, it discriminates, and it doesn't reflect an hierarchical structure. Classifications such as ICD-10 has 19,000 plus codes, but a terminology such as SNOMED CT has more than 300,000 concept IDs. Both serve important purposes, but different purposes. Classifications in healthcare provide a big picture view of that healthcare, they add statistical value to data, and they provide reporting of data at all management levels. Terminologies provide operational decision making, data retrieval at that operational level, decision support systems and point of care analysis, and they can also be used in the electronic health record. The uses of aggregated health data are many. That health data is used to support decisions and policy, epidemiological research, to conduct large data set analysis. It provides a basis for monitoring public health performance and trends, and it also plays an important role in case mix and activity-based funding. An overview of ICD-10 ACHI ACS. ICD-10, or the International Statistical Classification of Diseases and Related Health Problems, is the international standard for reporting diseases and health conditions recorded on clinical records, including death certificates and health records. ICD-10 is an Australian modification or expansion of the World Health Organization's ICD-10. In Australia, ICD-10 is used by the Australian Bureau of Statistics to classify causes of death and report mortality data. ICD-10 is used to classify diseases and health conditions and report morbidity data. ICD-11, the next iteration of ICD-10, will become the international standard for reporting diseases and health conditions on 1 January 2022. In Australia, however, there is no decision yet as to how or when ICD-11 will be implemented. The Australian Classification of Health Interventions, or ACHI, is used in conjunction with ICD-10-AM to classify interventions in admitted care. ACHI is based on the Medicare Benefit Schedule, but expanded to include many other interventions as well. ICD-10-AM ACHI ACS is used to classify all admitted care. And the Australian Refined Diagnosis Related Groups classification is used in admitted acute care. ICD-10-AM is also used in other ABF classifications besides acute care. It is also used in subacute and non-acute care and emergency care. The Australian coding standards have been developed for use with ICD-10-AM and ACHI to support national consistency and accuracy of coded data. They apply to public and private hospitals in Australia. ICD-10-AM ACHI ACS 11th edition is the current edition in use. The classification system is regularly updated, now over a 3-year development cycle, and that is to balance currency and stability against the burden of implementation. The 12th edition of ICD-10-AM ACHI ACS is currently under development and nearing finalisation. It is anticipated to be approved by the Pricing Authority, IHPA's board, in November 2021, and then released early in 2022 and proposed for implementation from 1 July 2022. IHPA's activity-based funding classifications. IHPA is responsible for the development of a number of ABF classifications. Besides AR-DRGs used in admitted acute care, IHPA is responsible for developing the Australian National Subacute and Non-Acute Patient Classification, or ANSNAP, the AMHCC, which is the Australian Mental Health Care Classification, the AECC, which is the Australian Emergency Care Classification, and UDGs, or Urgency Disposition Groups, which is used for emergency services, Tier 2, a non-patient-based non-admitted care classification, and lastly, the ATTC, the Australian Teaching and Training Classification. Just to reiterate the relationship between the ICD-10-AM ACHI ACS classification system, which is used for all admitted care, to note that it is also used in AR-DRGs and SNAP, and also in the Australian Emergency Care Classification, where a subset of ICD-10-AM is used in the Emergency Department shortlist. AR-DRGs provide a clinically meaningful way to relate the number and type of patients treated in a hospital to the resources required in that treatment. They group patients with similar diagnoses requiring similar hospital services. AR-DRG version 10 is the most recent version. It is regularly updated in parallel with ICD-10-AM ACHI ACS in the 3-year development cycle. And again, that is to balance currency and stability against the burden of implementation. AR-DRG version 11 is currently under development and nearing finalisation. It is anticipated that it will be approved by the Pricing Authority, IHPA's board, in February 2022, released in July of that same year, and then it will be proposed for use in pricing in July 2023. That concludes my part of the presentation today. I will now hand over to my colleague, Natalie Bryant, who will provide an overview of IHPA's other ABF classifications.
Thanks, Anne. The Australian National Subacute and Non-Acute Patient Classification, or ANSNAP, is the classification used for admitted rehabilitation care, palliative care, geriatric evaluation and management care, or GEM-care, psychogeriatric care, and non-acute care. ANSNAP was first developed in 1997 and has been refined 3 times since then. The most recent version, version 4, was released in May 2015 and has been used for pricing admitted subacute and non-acute care since 1 July 2016. ANSNAP version 5 is currently under development and approaching finalisation. It is anticipated that it will be approved by the Pricing Authority in November of 2021 and released shortly thereafter. It is proposed to be used for pricing from 1 July 2023. IHPA considers ANSNAP version 5 to be a modest refinement of the classification. The fundamental structure, including the 5 care types, has been retained. In version 5, IHPA sought to better explain the relationship between patient complexity and episode costs using multiple existing and new clinical assessment tools and other variables. The most significant change is the introduction of a measure of frailty in the GEM and non-acute care types. I will now walk through a simple patient journey. An elderly patient is admitted to hospital for a hip replacement due to osteoarthritis. Using the diagnosis and intervention codes, this episode is classified to the adjacent DRG of I-33, hip replacement for non-trauma. Depending on the level of complexity, it would either go to the A or B class. The patient is then transferred to a subacute ward for rehabilitation. Using the appropriate diagnosis codes and the level of functioning determined at the commencement of the episode, this episode of care would be classified to ANSNAP 4A22, orthopaedic conditions, all other, including replacements, weighted fin motor 50 to 67. Following discharge, the patient attends an outpatient hydrotherapy clinic for further rehab. This service contact or service event will be classed to the Tier 2 Non-Admitted Services Classification class of 4005 for hydrotherapy. IHPA has 2 classifications for emergency care, the Australian Emergency Care Classification for emergency departments and the Urgency Disposition Groups for emergency services. Emergency department care is classified using type of visit, episode end status, diagnosis and complexity, whereas emergency services only uses type of visit, episode end status and complexity. The Australian Emergency Care Classification version 1 replaced the Urgency-Related Groups classification for pricing of emergency department care from 1 July 2021. The Urgency Disposition Groups classification continues to be used for the pricing of emergency services. I will now present another simple patient journey. A patient presents to the emergency department following a car accident in which they suffer a hip fracture. Due to the type of visit, the complexity, the diagnosis and the episode end status, this episode of care is classified to the Australian Emergency Care Classification class of E2020, pelvic and femoral fractures. Depending on the level of complexity, it would go to either the A or B class. The patient is then admitted for a hip replacement due to trauma. Using the diagnosis and intervention codes, this episode is classified to the adjacent DRG of I-03, hip replacement for trauma. Depending on the level of complexity, it would go to either the A or B class. The patient is then transferred to a subacute ward for rehabilitation care. Using the appropriate diagnosis codes and the level of functioning determined at the commencement of the episode, this episode of care would be classified to the ANSNAP class of 4A22, orthopaedic conditions, all other, including replacements, weighted fin motor 50 to 67. The Australian Mental Health Care Classification is the classification used for classifying of mental health services in Australia. It provides a way of describing the factors that inform the types and cost of mental health care. It includes all services where specialised mental health care is provided, and it is used to classify both admitted and community episodes of care. The Australian Mental Health Care Classification version 1 was approved by the Pricing Authority in February 2016. It is proposed to be used for pricing of admitted mental health care from 1 July 2022, replacing the AR-DRGs. And it will be continued to be used for shadow pricing of community mental health care. The Australian Mental Health Care Classification has 6 major splitting variables. The first 3 variables are categorical and the remaining variables are measures of complexity. The categorical variables are setting, mental health phase of care, and age group. The measures of complexity are mental health legal status, Health of the Nation Outcomes Scale, or HONOS score, and the Life Skills Profile 16, or LSP 16 score. Mental health legal status is only used within the admitted setting for consumers with a mental health phase of care of acute between the ages of 18 and 64. The Life Skills Profile 16 score is only used within the community setting for consumers with a moderate HONOS complexity. The unit of count for the AMHCC is a phase of care. That is because it is recognised that episodes of care within mental health care services can be very long, and the level of need within an episode of care can vary greatly. I will now walk through a consumer journey. A consumer attends a community health service due to increasing intensity of symptoms and risk. Due to the mental health phase of care, age, and HONOS scores of the consumer, this phase of mental health care is classified to the AMHCC N class of 212A, Community Acute, 18 to 64 years, high HONOS complexity. The consumer is then referred to an admitted mental health service and is admitted for a period to focus on their psychosocial functioning. Again, due to the mental health phase of care, age, and HONOS scores, this consumer's phase of care is classified to the AMHCC N class of 122A, admitted, functional gain, 18 to 64 years, high HONOS complexity. Following a period of admitted care, the consumer is then discharged and referred back to the community mental health service, where they continue support to focus on psychosocial functioning. Again, due to the mental health phase of care, age, and HONOS scores, and LSP scores, this mental health phase of care is classified to the AMHCC N class of 222B2, Community Functional Gain, 18 to 64 years, Moderate HONOS, and LSP complexity. Here is a summary of IHPA's ABF classifications. Today we have covered in detail the classifications for admitted acute care, subacute and non-acute care, mental health care, and emergency care. The two classifications we have not covered include non-admitted, the Tier 2 non-admitted services classification, and teaching and training, the Australian Teaching and Training classification. The Tier 2 non-admitted services classification is not a patient classification. It is a classification of clinics. The structure of the classification is first differentiated by the nature of the non-admitted service provided. The teaching and training classification is also not a patient classification. It is a classification of health professionals and their training, and it is oriented on the key concepts of profession and training stage. So where to next? IHPA are in the process of developing a new classification for non-admitted care. This will replace the Tier 2 non-admitted services classification. It is anticipated that the new non-admitted care classification will be patient-based and look at complexity and other factors that influence the cost of care in non-admitted services. IHPA will also be undertaking work in relation to aged care. Join us for a live Q&A webinar on Wednesday, the 20th of October 2021 at 12 noon Australian Eastern Daylight Savings Time. Registration details are on the IHPA website through the events page. Anne and I would like to thank you for joining us today for this webinar on how classifications are developed at the Independent Hospital Pricing Authority. Thank you very much.